Welcome to our exploration of the respiratory system, the essential network that powers every breath you take. In this video, we'll break down the mechanics of breathing, the protective features of your lungs, and the science behind gas exchange. Whether you're a student, a health enthusiast, or simply curious about how your body works, this journey will help you understand the intricacies of respiration. Let's start by setting the stage for why breathing is so vital and how the respiratory system keeps us alive and thriving. Respiratory system is equipped with several protective mechanisms to ensure safe and efficient breathing. These include mucus that traps dust and pathogens, cilia that sweep contaminants out of the airways, and reflexes like coughing and sneezing to expel irritants. Together, these defenses keep the lungs clear and reduce the risk of infection or injury. Understanding these mechanisms highlights the importance of respiratory health and the body's natural ability to protect itself from environmental threats. Partial vacuum exists in the intrapleural space, the area between the lungs and the chest wall. This negative pressure is crucial for keeping the lungs inflated and preventing collapse. It acts as a buffer, balancing the forces that pull the lungs inward and those that push the chest wall outward. If this vacuum is disrupted, such as by injury or disease, the lungs can collapse, leading to serious health issues. Maintaining this delicate balance is essential for normal breathing. Boyle's law describes the relationship between pressure and volume in gases. In the context of breathing, as the volume of the thoracic cavity increases during inspiration, the pressure inside the lungs decreases, allowing air to flow in. Conversely, when the volume decreases during expiration, the pressure rises and air is expelled. This fundamental principle explains the mechanics behind every breath and underscores the importance of pressure changes in pulmonary ventilation. Respiratory muscles, including the diaphragm and intercostals, play a key role in changing the volume of the thoracic cavity. When these muscles contract, the chest expands, decreasing pressure and drawing air into the lungs. Relaxation of these muscles causes the chest to contract, increasing pressure and pushing air out. Lung elasticity also contributes to these volume changes, ensuring efficient airflow during both inspiration and expiration. Several physical factors influence pulmonary ventilation, including airway resistance, alveolar surface tension, and lung compliance. Airway resistance affects how easily air moves through the respiratory tract, while surface tension in the alveoli can cause them to collapse if not regulated by surfactant. Lung compliance measures how easily the lungs can expand. These factors together determine the efficiency of breathing and the energy required for ventilation. Lung volumes refer to the different amounts of air moved in and out of the lungs during various phases of breathing. These include tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. Each volume provides insight into respiratory health and function. By measuring these volumes, clinicians can assess lung capacity and detect abnormalities in breathing patterns. Dead space in the respiratory system refers to areas where air does not participate in gas exchange. Anatomical dead space includes the airways, while alveolar dead space results from non-functional alveoli. The total dead space is the sum of both. Understanding dead space is important for evaluating respiratory efficiency and identifying potential issues in gas exchange. Pulmonary function tests such as spirometry provide valuable information about lung health. These tests measure respiratory volumes and capacities, helping to distinguish between obstructive and restrictive lung diseases. By analyzing the rate and amount of air movement, clinicians can diagnose conditions like asthma, bronchitis, and fibrosis and monitor the effectiveness of treatments. Alton's law states that the total pressure exerted by a mixture of gases is equal to the sum of the pressures exerted by each individual gas. In the respiratory system, this principle helps explain how oxygen, carbon dioxide, and other gases move between the lungs and blood. Partial pressures are directly related to the concentration of each gas, influencing diffusion and gas exchange. Henry's law describes how gases dissolve in liquids, such as oxygen and carbon dioxide in blood. The amount of gas dissolved depends on its partial pressure and solubility. For example, carbon dioxide is much more soluble in plasma than oxygen. This law is crucial for understanding how gases are transported and exchanged during respiration. Atmospheric air and alveolar air differ in composition due to gas exchange, humidification, and mixing of gases. Alveolar air contains more carbon dioxide and water vapor, while oxygen levels are lower compared to atmospheric air. These differences are essential for efficient gas exchange and maintaining proper respiratory function. Thoracic cavity is subject to various pressures that influence breathing. Atmospheric pressure surrounds the body, while intrapulmonary and intrapleural pressures fluctuate with each breath. Negative, positive, and zero respiratory pressures are all described relative to atmospheric pressure, and these differences drive the flow of air in and out of the lungs. Intrapulmonary pressure, also known as intraalveolar pressure, is the pressure within the alveoli. It fluctuates during breathing and always eventually equalizes with atmospheric pressure. These changes are essential for the movement of air into and out of the lungs, ensuring proper ventilation and gas exchange. Intrapleural pressure is the pressure within the pleural cavity. It is always negative relative to atmospheric and intrapulmonary pressures, typically about 4 mHg less than intrapulmonary pressure. This negative pressure is vital for keeping the lungs inflated, and any disruption can lead to lung collapse. 2. Inward forces promote lung collapse. The lungs' natural tendency to recoil due to elasticity and the surface tension of alveolar fluid. These forces constantly work to reduce the size of the lungs and alveoli, making the maintenance of negative intrapleural pressure crucial for lung stability. One outward force tends to enlarge the lungs, the elasticity of the chest wall, which pulls the thorax outward. This force counteracts the inward forces and helps maintain lung inflation, ensuring a balance that allows for normal breathing. Transpulmonary pressure is the difference between intrapulmonary and intrapleural pressures. It keeps the lung spaces open and prevents collapse. The greater the transpulmonary pressure, the larger the lungs will be. If intrapleural pressure equals intrapulmonary or atmospheric pressure, the lungs collapse. Atelectasis refers to lung collapse, which can occur due to plugged bronchioles or pneumothorax, air in the pleural cavity. Treatment involves removing air with chest tubes, and once the pleurae heal, the lung can reinflate. This condition highlights the importance of maintaining proper pressure relationships in the thoracic cavity. Pulmonary ventilation consists of inspiration and expiration. It is a mechanical process that depends on volume changes in the thoracic cavity. These volume changes lead to pressure changes, which in turn drive the flow of gases to equalize pressure between the lungs and the atmosphere. Ohm's law is fundamental to understanding pulmonary ventilation. As the volume of the thoracic cavity increases, pressure decreases and air flows in. When the volume decreases, pressure increases and air flows out. This inverse relationship is mathematically expressed as P1V1 equals P to V2, and it governs the movement of air during each breath. Inspiration is an active process involving the diaphragm and external intercostal muscles. When the diaphragm contracts, it moves downward and flattens, increasing thoracic volume. The intercostals lift the rib cage, further expanding the chest. These actions decrease pressure in the lungs, allowing air to flow in. As the thoracic cavity expands during inspiration, the lungs are stretched, causing intrapulmonary pressure to drop below atmospheric pressure. Air flows into the lungs down this pressure gradient until equilibrium is reached. Meanwhile, intrapleural pressure becomes even more negative, supporting lung inflation. During vigorous exercise or in certain conditions, forced inspiration occurs. Accessory muscles like the scalenes, sternocleidomastoid, and pectoralis minor are activated, along with the erector spinae muscles. These actions further increase thoracic volume, creating a larger pressure gradient and drawing in more air. Expiration is usually a passive process. Inspiratory muscles relax, the thoracic cavity volume decreases, and the lungs recoil. This volume decrease causes intrapulmonary pressure to rise above atmospheric pressure, pushing air out of the lungs. Forced expiration, such as during exercise, is an active process involving abdominal and internal intercostal muscles. Sequence of events during inspiration and expiration involves coordinated changes in thoracic volume and pressure. As the chest expands, air is drawn in. As it contracts, air is expelled. This rhythmic process is essential for continuous gas exchange and maintaining oxygen and carbon dioxide levels in the body. During inspiration and expiration, both intrapulmonary and intrapleural pressures change dynamically. These fluctuations are illustrated in graphs and diagrams, showing how pressure gradients drive airflow and maintain lung function. Understanding these changes is key to grasping the mechanics of breathing. Besides normal breathing, several non-respiratory movements can move air in and out of the lungs. These include coughing, sneezing, crying, laughing, hiccups, and yawns. Most are reflex actions, but some are voluntary. They can modify the normal respiratory rhythm and serve protective or communicative functions. Airway resistance is a major factor influencing the ease of air passage and the energy required for ventilation. It is mainly caused by friction in the airways. The relationship between flow, pressure, and resistance determines how efficiently air moves through the respiratory tract. Resistance in the respiratory tree is usually insignificant due to large airway diameters and progressive branching. However, resistance can increase in medium-sized bronchi and disappear at terminal bronchioles, where diffusion drives gas movement. Any significant resistance can impact breathing efficiency. Severe constriction or obstruction of bronchioles, as seen in acute asthma attacks, can prevent life-sustaining ventilation. Breathing becomes more strenuous and ventilation may stop. Epinephrine can dilate bronchioles and reduce air resistance, restoring airflow and improving breathing. Surface tension in the alveoli is caused by the attraction of liquid molecules at the gas-liquid interface. Water coats the alveolar walls, tending to shrink them to their smallest size. Surfactant, produced by type II alveolar cells, reduces surface tension and prevents alveolar collapse, ensuring efficient gas exchange. Premature infants often lack sufficient surfactant, leading to infant respiratory distress syndrome (IRDS). Increased surface tension causes alveoli to collapse after each breath, requiring complete reinflation during inspiration. This condition is common in premature babies and highlights the importance of surfactant in lung function. Lung compliance measures how easily the lungs can expand with a given change in transpulmonary pressure. High compliance means easier expansion, while low compliance requires more energy to breathe. Factors affecting compliance include lung tissue distensibility and surfactant production. Compliance can be diminished by non-elastic scar tissue, fibrosis, reduced surfactant production, or decreased flexibility of the thoracic cage. Chronic inflammation or infections like tuberculosis can replace normal lung tissue with scar tissue, making breathing more difficult and requiring more energy. Total compliance of the respiratory system is also influenced by the compliance of the thoracic wall. Deformities, ossification of costal cartilage, common in old age, or paralysis of intercostal muscles can decrease thoracic wall compliance, affecting overall respiratory efficiency. Respiratory volumes and capacities are assessed using tools like spirometers. These measurements help determine a person's respiratory status and identify abnormalities. Electronic devices are commonly used today, providing accurate and efficient assessments for clinical diagnosis. Tidal volume is the amount of air moved in and out with each breath, averaging about 500 ml. Inspiratory reserve volume is the extra air that can be inhaled beyond tidal volume, while expiratory reserve volume is the extra air that can be expelled. Residual volume is the air that always remains in the lungs, keeping alveoli open. Expiratory capacities are combinations of two or more volumes. Inspiratory capacity is the sum of tidal and inspiratory reserve volumes. Functional residual capacity combines residual and expiratory reserve volumes. Vital capacity is the sum of tidal, inspiratory, and expiratory reserve volumes, while total lung capacity includes all volumes. Diagrams of respiratory volumes and capacities help visualize the different measurements and their relationships. These illustrations are useful for understanding how lung function is assessed and how various conditions can affect breathing. Dead space includes anatomical dead space, airways not involved in gas exchange, alveolar dead space, non-functional alveoli, and total dead space, some of both. Understanding these types helps evaluate respiratory efficiency and detect issues in gas exchange. Spirometry distinguishes between obstructive and restrictive pulmonary diseases. Obstructive diseases increase airway resistance and lung volumes, while restrictive diseases reduce lung capacity due to compromised expansion. These tests are essential for diagnosing and monitoring respiratory conditions. Pulmonary function tests can measure the rate of gas movement, such as forced vital capacity, FVC, and forced expiratory volume, FEV. Healthy individuals expel 80% of FVC in the first second, while those with obstructive disease exhale less. These measurements provide insight into lung health. Minute ventilation is the total amount of gas flowing in and out of the respiratory tract per minute. Alveolar ventilation rate (AVR) is a better indicator of effective ventilation, as it accounts for dead space, tidal volume, and breathing rate. Increasing tidal volume improves AVR more than increasing frequency. Gas exchange occurs between the lungs and blood, external respiration, and between blood and tissues, internal respiration. Both processes rely on the basic properties of gases and the composition of alveolar gas. Understanding these mechanisms is essential for grasping how oxygen and carbon dioxide are transported in the body.